So I'm trying to share the tips. So it's showing that host has disabled the participant.
No. That we will just put your video on. Mr. Nimesh.
Yes, sir.
Please enable Dr. Parul to share her screen, please.
Now she can do.
Okay. So first, Dr. Parul, just if you want, you can just try sharing your screen.
Yes, sir.
And then unshare it, right?
Okay. So can you see the screen now?
No, not able to see. So what you would do, I am sure you must have done it before in other Zoom meetings.
Yes, sir.
You have to open your PPT presentation before you do. Yes, it is there, right? Thank you. So you can make it full screen.
Yes, sir.
Sir, it should be recorded, na? We should start recording.
Once we start, still not started, right?
Okay.
So can you see the full screen now?
Right. Now you can unshare your presentation again.
Stop sharing.
And let me unshare it. Yes. So, Mr. Nimesh, I will, when I tell you, then start recording them, right?
Okay, sure.
So, just give us a countdown of 3, 2, 1, and then we will start. Yes. Mr. Nimesh?
Ji, sir.
Yeah. You can start, Mr. Nimesh. Yes.
Okay, sir.
So should we start now?
Yes, sir. You can proceed. 3, 2, 1.
So good morning to all the viewers. So once again, we welcome you to the teaching class of Department of Urology, SMS Medical College, Jaipur. And so today we have one of those interdepartmental classes. We started with uronephrology, and now we have a class with the radiotherapy department and the radiation oncology department. So we are privileged to have today with us Dr. Parul Gupta, who is assistant professor in Department of Radiotherapy and Radiation Oncology. Thank you, Dr. Parul, for coming to our session. And I would now request Dr. Parul to please proceed and share her presentation and start deliberating. Thank you.
Thank you, sir. Thank you so much for your kind words. And I'm honored to be here. So today's topic of discussion is role of radiation therapy in urological malignancies. So I'll start with the brief introduction about radiation. Radiation is the emission and propagation of energy through space or material medium, which may be in the form of particles or waves. It can be of two types, electromagnetic radiation and particulate radiation. This slide is showing the electromagnetic spectrum in which we go from radio waves to X-rays and gamma rays. When we go from radio waves to X-rays and gamma rays, the energy increases and the wavelength decreases. So X-rays and gamma rays have enough energy for ionizing the atom. These are the rays which we are concerned with in radiation oncology. So depending on the ionization property, radiation is classified as ionizing or non-ionizing. Ionizing can be of particulate type or waves type. Particulate radiation comprises alpha particles, beta particles, or electrons, and waves are of two types. It can be of gamma rays, which are used in cobalt-60 radiotherapy, and X-rays, which are used in linear accelerator and other newer machines. We are not concerned with the non-ionizing radiation in our department, which can't remove the electrons from the atoms. So they are not used in the therapeutic part. They are used in the diagnostic part of the radiation. So clinical radiation oncology uses photons in the form of megavoltage X-rays or gamma rays that are electromagnetic, and particulate radiation in the form of electrons, protons, neutrons, or alpha particles in the treatment of malignancies and some benign conditions. So it's a very vast topic. I'll try to be concise and share as much as possible. So we will be discussing prostate cancer, carcinoma bladder, penile cancer, and testicular malignancy, the role of radiotherapy in these. Starting with the radiotherapy in prostate cancer, I'll directly start with the staging. With appropriate clinical checkup and radiological imaging, we can come up with the staging of the tumor. T1 is when the tumor is clinically inapparent and it is not palpable. T1A is when the tumor is incidental histological finding in 5% or less of the tumor resected. T1B when it is in more than 5% of tumor resected. And T1C is when the tumor is identified by the needle biopsy, which is found in one or both sides, but it is not palpable. T2 is when the tumor is palpable but is confined within the prostate. T2A is when it involves one half of one side or less. T2B is when it involves more than half of one side but not both sides. And T2C is when it involves both sides of the prostate. T3 is when the tumor invades when the tumor is extraprostatic. That is, it's not fixed, but it does not invade the adjacent structure. T3A is when the extraprostatic extension is there, which can be unilateral or bilateral. And T3B is when the tumor invades seminal vesicles. T4 is when the tumor is fixed or invades adjacent structures like some external sphincter, rectum, bladder, levator muscles, or pelvic wall. Pathological staging is similar to the clinical staging, but it does not involve T1. It only involves T2, T3, and T4 tumors. Regional lymph nodes are N0 is when no regional lymph nodes are there, N1 when there is metastasis in the regional lymph nodes. In distant metastasis, there is M0 when no mets, and M1A when non-regional lymph nodes are involved, M1B when bone is involved, and M1C when bone other side are involved with or without bone disease. So clinically localized disease is staged in stage 1, 2, and 3 without nodal or distant mets. And when there is nodal mets, the stage becomes stage 4A, and when there is distant mets, the stage becomes stage 4B. Gleason score, when it is 6 or less, it is grade group 1. When it is 7, the grade group is 2. 3 plus 4 is pattern. When the pattern is 4 plus 3, the grade group is 3. And when the pattern is 4 plus 4 or 4 is 8, the grade group is 4. And 5 when the Gleason score is 9 to 10. So with the help of appropriate T staging, PSA levels, and grade grouping of the Gleason score, we can assign the patient in the risk category for localized prostate cancer, which is important for the management. So very low risk group patients involves the patient which have all of the following. That is clinically T1C disease, grade group 1, PSA is less than 10 nanogram per ml, fewer than 3 prostate biopsy fragments are positive, and all biopsy fragments should have less than 50% cancer in each core. And the PSA density should be less than 0.15 nanogram per ml per gram. It is low risk group when it has all of the following but does not classify for very low risk. That is clinically T1 or T2A disease, grade group 1, and PSA levels are less than 10 nanogram per ml. It is intermediate risk group when it has all of the following. That is when it has no high risk or very high risk group features, and it has one of the intermediate risk group factors like clinically T2B, T2C disease, grade group 2 or 3, and PSA level 10 to 20. It is favorable intermediate which has when it has all of the following. When it has only one intermediate risk group factor which have already enumerated, and grade group 1 or 2 only, and less than 50% biopsy codes are positive. It is unfavorable intermediate when it has 2 or 3 IRS, grade group 3, or more than 50% biopsy codes are positive. If any one of this is present, then it is be categorized as unfavorable intermediate risk group. It is high risk group when it has no very high risk features and it has only one high risk feature, then only it will be categorized in high risk group. It can be clinically T3A, that is extraprostatic extension, or grade group 4 or 5, or when there is PSA level of more than 20 nanogram per ml. It is very high risk group when it has at least one of the following, that is any one of these can be should be present to categorize in very high risk group, that is clinically T3B or T4 disease. Primary gleason pattern is 5. 2 or 3 high risk features are present, and more than 4 codes with grade group 4 or 5 are there.
Dr. Parul, I will just interrupt here.
Yes, sir.
First, put your video, your face is not seen on the video. So just adjust your laptop in a way that we can see your face completely. We can't see your face. Can you just adjust it a little more?
Can you see?
No, the whole face is not coming. Yes, better. Still a little better.
Now, sir?
A little better. You just make it even more. I think this is better. Okay, fine.
Okay.
And secondly, I would request you to focus more on the radiotherapy aspect, because these things that we are discussing almost every day,
Okay, sir.
the grade and the everything, right?
Okay, sir.
Yeah, thank you.
So various treatment modalities are surgery, radiotherapy, hormonal therapy, and chemotherapy and immunotherapy. So risk category wise treatment all must be knowing, so I'll skip this. So I'll emphasize on one point only. If the life expectancy of the patient is less than 5 years, in very low and favorable intermediate risk group patients, no imaging or treatment is recommended. Only observation should be given or should be preferred unless patient becomes symptomatic, or when the symptoms appear or imminent, that is when the PSA reaches more than 100 nanogram per ml, ADT should be started. So radiotherapy in prostate, it can be given by 2 modalities, by external beam radiotherapy or by brachytherapy. In external beam radiotherapy, the source is kept away from the patient, that is approximately 80 to 100 centimeter away from the patient. And in the brachytherapy, the source is given is kept in the proximity to the patient tumor or inside the tumor. External beam radiotherapy can be is of various types in prostate cancer. It can be radical, adjuvant, salvage, and palliative, and which we will see further the indications of all. And brachytherapy, it can be given by as monotherapy or as boost. So the indications of radiotherapy in localized prostate cancer. In very low and favorable intermediate risk group, it can be given as external beam radiotherapy alone, or brachytherapy as monotherapy. In unfavorable intermediate risk group, it should be given as external beam radiotherapy with prophylactic pelvic node irradiation with androgen deprivation therapy of 4 to 6 months, or EBRT plus brachytherapy boost plus ADT. For high and very high risk group patients with the expected survival of more than 5 years, we should give EBRT plus prophylactic pelvic nodal irradiation plus androgen deprivation therapy of 2 to 3 years, or we can combine it with brachytherapy boost. The indications of post-RP adjuvant therapy is when there is pathological T3 disease, that is extraprostatic extension, and when there is positive margins, or when there is seminal vesicle involvement. And the indications of salvage therapy post-prostatectomy is when after RP, undetectable PSA becomes detectable and increases on 2 measurements, or when the PSA remains detectable after RP after 4 weeks of surgery. In the metastatic disease, when there is nodal involvement and expectancy is more than 5 years, RT to the prostate should be given along with the pelvic nodes with long-term neoadjuvant concomitant or adjuvant ADT plus abiraterone for 2 years. And when the expectancy is less than 5 years, ADT or observation should be given. In metastatic disease, there are various modalities of treatment according to the volume of the disease and hormone sensitivity. Various modalities can be applied, like androgen deprivation therapy plus minus palliative radiotherapy and bisphosphonates. RT can be given to the low volume metastatic disease with androgen deprivation therapy in metastatic castration naive prostate cancer. According to the STAMPEDE trial, it improves failure-free survival, but not overall survival, and dose is 55 gray in 20 fraction, or brachytherapy alone can be given in 6 gray 6 fraction only. Curative SBRT, stereotactic body radiotherapy, can be given to bone oligometastatic disease, that is when there is less than 4 bone mets, and upfront ADT with chemotherapy can also be given. So the goal of radiation therapy in localized disease is to eliminate the tumor in the prostate completely, where the prostate remains itself in situ with the least possible harm to bowel, bladder, and erectile dysfunction. The radical radiotherapy is the principal treatment option for clinically localized prostate cancer. The various techniques by which we give radical radiotherapy are conventional radiotherapy, conformal radiotherapy, IMRT, that is intensity modulated radiotherapy, IGRT, that is image guided radiotherapy, SBRT, stereotactic body radiotherapy, and proton beam therapy, which is the newest of all techniques. Conventional EBRT is not now preferred in prostate cancer as it gives high dose to the adjacent tissues and causes high toxicity. So I'll be skipping this. Dose escalation. With the help of 3D conforming planning techniques, like IMRT and IGRT, high doses can be given to the prostate, which results in the overall survival improvement in intermediate risk group and high risk group patients of approximately 8% and 6%. Image-guided radiotherapy is the procedure which refines the delivery of therapeutic radiation therapy by applying image-based relocalization. Like in this image, we can see the simulation image, which we do before the treatment starts. The prostate is coming inside the boundary, and rectum is also coming inside the boundary of which we contour for giving the radiation. But during the treatment, when we image the patient, the prostate is, the treatment boundary slightly involves the rectum because of the rectal distension. So in this image, we can see the rectum is coming inside the treatment boundary. We can reposition the patient and minimize the toxicity for a rectum accordingly. So in this modality with the image guidance techniques, we can daily image the patient before giving radiotherapy to minimize the toxicity to the normal tissue and like rectum and bladder, and to maximize the dose to the prostate. Stereotactic body radiotherapy is a technique that delivers highly conformal, high-dose radiation in 5 or fewer fractions, which are safe to administer only with precise image-guided delivery. The various devices by which SBRT is given is CyberKnife, linear accelerator-based volumetric arc therapy, and flattening filter-free beams, and by tomotherapy. As per CR et al., 5-year biochemical progression-free survival after SBRT in low-risk group ranges up to 95%, in intermediate risk group to 84%, and high-risk group to 81%. So this image is showing the various cross-sectional images of SBRT. In the red boundary, it is the prostate, which is very, very tightly confined within the target, and very less dose is given to the surrounding tissue. That's why we can give very high doses per fraction in SBRT, and the treatment ranges only, treatment duration is only for 1 week, and the whole prostate is treated in only 1 week only. Proton beam therapy is the newest technique for delivering radiation therapy in prostate, and proton beam therapy delivers less radiation to the surrounding normal tissues like bone, muscle, vessels, and fat. And this is the image showing comparison between the IMRT and proton beam therapy. Like we can see, proton beam therapy gives very less radiation to the surrounding tissue, which is important for the secondary malignancy development in the future. And IMRT is giving radiation, slightly more amount of radiation in the adjacent tissues like fat and subcutaneous tissues. Coming to the result of the radical prostatectomy versus EBRT, Klein et al. Conducted study in the intermediate risk group prostate cancer patients where they found that 7-year biochemical recurrence-free survival was similar in radical prostatectomy and EBRT patients which are given more than 72 gray dose. And according to Kim Baiji et al., they found out that when they compared between RP and EBRT, 8-year biochemical failure-free survival was more in EBRT, that is 72% versus 44% in RP, and disease-specific survival was almost similar between the two. Now, a meta-analysis conducted by Wong et al. In the high-risk patient, we showed that RP has benefits on cancer-specific survival and overall survival, while RT, radiation therapy, was associated with better biochemical recurrence-free survival and metastasis-free survival. RT was associated with similar or even better survival outcomes compared to RP in patients with high Gleason score and high T stage. So we should prefer RT to RP in high T stage or high Gleason score. Coming to adjuvant radiotherapy, the indications are after radical prostatectomy, within 1 year of RP, we should give adjuvant radiotherapy, preferably within 5 months. It is indicated in PT3A disease when the pathological margins are positive, when seminal vesicles are involved, and when histological grade is 8 to 10, and when there is pathological lymph node involvement. Coming to results, the freedom from biochemical relapse when compared with RP plus RT gave freedom from biochemical relapse up to 51%. That was 25% with RP alone. That is, it doubles when RT is combined with RP in as adjuvant setting. And overall survival increases from 66% to 74% when we combine RP plus RT in adjuvant setting. The dose which is given is 66 days in 33 fractions. Salvage radiotherapy indications are undetectable PSA after RP, which becomes detectable, and 2 consequent increments, or the PSA which persists after RP. So PSA should be undetectable after 4 weeks after successful prostatectomy. In this slide, we can see that post-treatment PSA doubling time is directly related to the risk of distant mets when it increases from 0 to 12 months, and the incidence of distant mets decreases from 50% to 7%. So there are various factors which are associated with success of salvage RT, that is Gleason score. When there is Gleason score less than 6, diploid tumor DNA, no persistently detectable post-op PSA, lower PSA level before RT, greater post-operative PSA doubling time, that is more than 15 months, negative surgical margins, seminal cycle invasion is negative, and lesser delay in initiation of RT, that is within 5 months when we start the RT after RP. Also, when we combine EBRT plus ADD, according to the prospective RTOG 9601 trial, it improves the overall survival at 12 years from 73% to 76%. Coming to Sequelae of RT, I will not discuss conventional RT because it is now obsolete in case of prostate cancer. The highly conformal techniques now, IMRT and IGRT, there is very less incidence of the sequelae, that is very less than 5% of chronic urinary sequelae, that is cystitis, hematuria, urethral stricture, and bladder stricture, and less than 1% incidence of grade 3 and 4 urinary complication, which requires hospitalization, and 3 to 10% incidence of chronic intestinal or rectal sequelae, which requires management, that is chronic diarrhea, prostatitis, and rectal bleeding. There are some factors which are associated with increased RT toxicity, that are advanced age, volume of the rectum exposed to higher RT dose, concomitant use of ADT, and diabetes or IBD. Coming to SBRT from prostate cancer, oligometastatic disease, SBRT offers a higher local control rate in prostate cancer or bone oligomets, where oligomets is when there is 5 or less bony metastatic lesion, and should be evaluated with the aim of cure or delay modification of the systemic treatment. The indications are when the patients with limited mets to vertebra or paravertebral region, when ablation is the goal, when there is the concern for impending fracture or tumor encroachment on the spinal nerves or vertebra, we give SBRT to the vertebral region. And in the symptomatic patient where the lesion is immediately adjacent to the previously irradiated treatment field. Fable et al. Conducted a study in which 15 out of 205 patients received SBRT to bone mets with curative intention. After a median follow-up of 22 months, all patients revealed PSA progression-free survival of more than 12 months, and median PSA PFS was 23 months, and local PFS after 2 years was 800%. Coming to the role of palliative RT in prostate cancer, in the case of single painful bony mets, we can give 20 grain 5 fraction, 30 grain 5 fraction, or 800 centigrade single session. Single session is preferred in non-vertebral metastasis. For multiple painful bony metastasis, upper body irradiation of 600 centigrade and lower body irradiation of 800 centigrade can be given. If both are indicated, then there should be a gap of 2 to 3 weeks between the two. Whole skeletal irradiation is given by the non-sealed radionuclide therapy, in which strontium 89 offers more pain relief than heavy body RT, 66 versus 64%. Complete pain relief achieved in 3 to 4 weeks in 60% patients at 3 to 4 weeks and lasts for about 3 to 6 months. We can also give breast bud irradiation to the patients of prostate cancer which are receiving androgen deprivation therapy to prevent gynecomastia. Electron beam therapy is given of 9 to 12 MeV when the field size is 7 to 9 centimeter circular field, and the dose is 800 centigrade single fraction is given. Coming to prostate brachytherapy, brachytherapy in prostate can be given by two types, is of interstitial type and can be permanent or temporary. Permanent is given in very low dose rate, and it is given by iodine 125 or palladium 103 source, which are permanently implanted in properly selected patients. Temporary high dose brachytherapy using iodine 192 source is used and using afterloading catheters. Prostate brachytherapy as monotherapy is given when the life expectancy is more than 10 years. As monotherapy, it is given in very low and favorable intermediate risk group, as we already discussed, and as a boost, it is given in unfavorable intermediate and high and very high risk group. And there should be a prostate volume of less than 50 ml for brachytherapy. The contraindication of brachytherapy is where the life expectancy is less than 5 years, TORP defect, and inflammatory bowel disease, and the volume is more than 90 ml. So this picture is showing the brachytherapy, HDR brachytherapy, that is the temporary technique in which the afterloading catheters are inserted. Loading catheters are inserted inside the prostate. These afterloading catheters are connected with the guide wires. This is the machine, HDR microselectron machine, which houses the source of iridium 192, which we can remotely operate from the console room. The source travels from these guide wires to the afterloading catheters, and we can determine the plan by sitting in the console room and plan accordingly to give prostate the desired treatment. Coming to the outcome of the brachytherapy, Zalewski et al. Conducted a study with low dose rate permanent brachytherapy. They found out that 5 years PSA relapse-free survival in low risk group was 98% and intermediate risk group was 95% with brachytherapy alone. Kishan AU et al. Compared between the RP, EBRT plus ADT and EBRT plus BT in intermediate risk group patients. They found out that cancer, 5-year cancer specific mortality, 5-year distant mets rates, and all cause related mortality was least in EBRT plus brachytherapy group. In conclusion, among intermediate risk group patients, EBRT plus brachytherapy was associated with significantly better cancer specific survival and longer time to distant mets. Salvage radiotherapy can be considered in men with biochemical recurrence after external beam radiotherapy. Yamada et al. Found out that the cancer-specific survival was 96% with salvage radiotherapy and biochemical relapse-free survival was 88%. So the relative toxicities of RT, EBRT, and BT is when BT is given by brachytherapy is given along, the impotence rate is 24%. EBRT plus BT is given together, the impotence rate becomes 40%. EBRT alone, it is 45%. With now sparing RP, it is 66%. With RP alone, it is 75%. And urinary control, when RP is given, it is 35%, and RT is given, that then there, it is very good. It gives very good urinary control of 97%. Coming to radiotherapy in carcinoma urinary bladder. T1 stage is when there is subepithelial connective tissue invasion. T2 when the tumor invades muscularis propria. T3 is when it invades perivesical tissue, and T4 when it involves the adjacent organs. N1 is when there is single lymph node involved in the true pelvis, N2 multiple regional lymph nodes involved in the true pelvis, and N3 when there is lymph node mets in the common iliac lymph nodes. M0 is no mets, and M1 is distal mets. So the indications of radiotherapy in carcinoma urinary bladder are as follows. It can be given as concurrent chemoradiation as a part of multimodality bladder sparing protocol in T2 to T4 N0 disease. It can be given as radical RT in inoperable cases. We can give new adjuvant radiotherapy for downstaging the disease. Adjuvant radiotherapy after surgery in pathologically T3, T4 disease, margins are positive, and when nodes are positive. It can be given in pelvic recurrence after radical prostatectomy, and it can be given as palliative therapy for metastatic disease. There is no role of RT in non-muscle invasive bladder cancer. Only there is role in muscle invasive bladder cancer. So in muscle invasive bladder cancer, surgery is preferred in poorly functioning bladder, extensive CIS in addition to invasive disease, pathological T1 grade 3 disease and hydronephrosis, and radiotherapy is preferred in older patients, in obese patients, in diabetics, in poor when there is poor anesthetic risk, solitary tumors in negative nodes when there is negative nodes and no extensive CIS, and no moderate or severe tumor related hydronephrosis, and when there is good pre-treatment bladder function. So coming to the treatment of the muscle invasive disease, in it we can give the primary treatment in stage 2 or 3A, that is clinically T2, T3 or T4, along with N1 disease. We can give bladder preservation concurrent chemoradiotherapy with cisplatin-based chemotherapy. Then we can reassess the tumor at 2 to 3 months. If the tumor remains, then we can give intravesical BCG or surgical consolidation, or we can go for new adjuvant cisplatin combination therapy followed by radical cystectomy. Adjuvant radiotherapy is given when there is pathological T3, T4 disease or margins of node positive. When there is N2 or N3 disease, we should go for downstaging the disease by systemic therapy followed by reassessment at 2 to 3 months. If there is CR or PR, then consolidation cystectomy or consolidation concomitant chemoradiation can be given. In stage 4A, that is clinically 4B disease, when the tumor is distant, adherent to the adjacent structure, only concurrent chemoradiotherapy or systemic therapy can be given. In 4A in distant mets, only systemic therapy is given. In metastatic disease, systemic therapy and palliative RT is given for pain. The side effects of RT includes acute effects are dysuria, urgency, frequency, and diarrhea. And chronic effects are hemorrhagic cystitis, bladder contractions, rectal strictures, and small bowel obstruction, which are very less in the newer techniques like IMRT and IGRT. Cystectomy is contraindicated in muscle invasive bladder cancer when there is lymph node mets which are unresectable because of bulk or proximal extent above the common iliac vessels. When there is evidence of extensive periureteral disease, when the bladder is fixed to the pelvic side walls, and when the tumor invades rectosigmoid colon. Hater et al. Studied 20,000 patients with bladder cancer and concluded that the bladder preserving options were equivalent to surgery in invasive bladder cancer, and similar results were attained by Monroe et al. In bladder cancer in case of surgery versus radical radiotherapy. Palliative radiotherapy is given when there is symptoms such as pain and hematuria in T4 bladder tumors, or when there is bone or other distant mets. The dose given is 20 grain 5 fraction. Coming to role of radiotherapy in benign malignancy, I'll skip the staging. Directly come to the management. The treatment modalities are topical radiotherapy. Topical therapy are given in only carcinoma in situ, laser therapy in varicose carcinoma only, and surgery radiotherapy and chemotherapy. Classically, primary benign lesion has to be treated surgically by excising wide local excision with 2 cm proximal margin, which offers excellent local control. Survival in penile cancer is largely driven by management of lymph node. That is, when there is clinically N0, the survival is 93%, and N3, it goes to 0% only. In varicose carcinoma, I like to say that radiotherapy is contraindicated because it has been shown to cause subsequent rapid malignant degeneration and metastasis. Indication of radiation therapy in CFN is radiation therapy is effective option for organ preservation in treatment of penile cancer in T1, T2, N0 tumors which are less than 4 cm, which can be managed by circumcision followed by brachytherapy alone or external beam radiotherapy with a dose of 65 to 70 gray or EBRT with concurrent chemotherapy with a dose of 65 to 70 gray. Prophylactic EBRT to inguinal lymph node may be considered for non-surgical candidates or those who decline surgery. For T1, T2 tumors which are more than 4 cm, circumcision followed by EBRT with concurrent chemotherapy of 45 to 50.4 gray to a portion or whole shaft is depending on the extent of the lesion, plus pelvic or inguinal nodes are irradiated, followed by a boost to the primary lesion to 60 to 70 gray. T3 or T4 lesions with or more positive lesions which are surgically unresectable, we can give circumcision followed by EBRT plus concurrent chemotherapy. If the margins are positive, post-penectomy, post-surgical EBRT 45 to 60 gray is given to the primary tumor, surgical scar, and inguinal and pelvic lymph nodes if inadequate dissection is done. Adjuvant chemoradiation in the nodal disease is given when there is palpable bulky inguinal lymph node or enlarged pelvic lymph node or palpable non-bulky inguinal lymph node in pathologically N2, N3 disease. The EBRT is given 45 to 50.4 gray and boost is given up to 65 to 70 gray. Palliative courses of 20 gray in 5 fraction or 30 gray, 10 fraction are given for painful metastasis. So this picture is showing the EBRT given to the penile cancer by telecobalt therapy. This is the bolt. This bolt is encasing the penile shaft by which we are giving the EBRT. Coming to results of EBRT, when Sarin et al. Found that the local control was 55% and penile preservation was 50% when the dose is given 60 gray in 30 fractions. Brachytherapy is given in penile cancer to when the clinical stage is T1B or T2 and the tumor is less than 4 cm in maximal diameter. It can be of interstitial brachytherapy when the source is implanted inside the penis with the iridium 192 and plesiobrachytherapy when the depth of tumor invasion is less than 5 mm and the radioactive material is molded around the tumor. This picture is showing the interstitial brachytherapy, which is given when the source needles are implanted inside the tumor and the source is passed in this needle for the treatment of the cancer. And this picture is showing the plesiobrachytherapy when the source is molded outside the penis. Coming to radiotherapy, role of radiotherapy in testicular malignancy, there is no role of radiotherapy in non-seminomatous germ cell tumors. Only radiotherapy is indicated in seminomatous germ cell tumors. So there is definitive RT role in seminoma stage 1, 2A and 2B in palliative setting for painful metastasis or cord compression. For seminoma stage 1, we can go for surveillance or adjuvant carboplatin or EBRT. For stage 2A and B, we can go for EBRT. And stage 2C and 3 are managed by chemotherapy only. For stage 1 seminoma, approximately 80% patients present with stage 1. The treatment is high inguinal orchidectomy followed by adjuvant radiation or chemotherapy or surveillance, which is preferred. In radiotherapy, dose given is in stage 1 seminoma, dose is 20 gray in 10 fraction with relapse rate of 1 to 5% and 5-year relapse-free survival is 96% and overall survival ranges to 100%. This slide is showing comparison between single dose carboplatin and radiotherapy. With 5-year relapse-free rate is 95% with carboplatin and 96% with radiotherapy. And recurrence occurs in retroperitoneal region with chemo and supradiaphragmatic region with radiotherapy. Surveillance in stage 1 is indicated in the patients who have contraindication to radio and chemotherapy and whose compliance is expected to be good. In seminoma stage 2A and 2B, treatment of radiotherapy is intradiaphragmatic radiotherapy with Stage 2A, we give 30 grade radiotherapy, and 2B, we give 36 grade radiotherapy by modified dog-leg technique. The recurrence rate with this technique is less than 10 to 20%. Overall survival ranges to 100% and disease-specific survival to 97 to 100%. The most common site of failure is supraclavicular fossa or mediastinum. The single agent carboplatin in stage 2 and 2B is inferior to radiotherapy. Overall failure rate with carboplatin ranges to 18%. There is no role of radiotherapy in 2C and 3 in upfront disease. Only we can give radiotherapy in relapse patients. So stage-wise treatment outcome in patients of seminoma, there is almost 5-year survival ranges to 100% with all the modalities, that is in stage 1, 2, and 3, with surveillance RT and carboplatin in 1, with RT and chemotherapy in 2, and with chemotherapy only in stage 3. Thank you so much for your patience with me. Thank you so much, sir.
Thank you. Thank you, Parul. Thank you very much. You can unshare your presentation. Thank you very much. Thanks for that elaborate description of management with radiotherapy with different urological malignancies. Yes. So I would request our residents and any faculty member, if they have any comment and query, please come up. We all know before they start their queries, if they have any, I would just give a small comment. Dr. Parul, we know all that in 1895, Röntgen discovered X-ray, and the first radiation therapy was given for a skin cancer just 4 years later in 1899. And just after a few years, radiotherapy was given in a case of CA prostate. That was in around 1910. And since then, I think radiotherapy has developed like anything, particularly with advances in imaging, with radiotherapy planning, and the software which has developed to plan, to develop exactly giving the radiation dose to the tumor, and the treatment delivery techniques, etc. They have definitely developed in the last few years so much that radiotherapy remains one of the very important treatment options, not in other malignancies, but also in urological malignancies. So we know in CA prostate, we often give radiotherapy in patients who have locally advanced CA prostate as an adjuvant radiotherapy, as a case of salvage radiotherapy after radical prostatectomy. And in CA bladder, we often give in patients who have T3 lesion, who have locally advanced CA bladder as a chemoradiation, starting with neoadjuvant chemotherapy followed by radiation therapy. In CA penis, definitely as an organ preserving surgery, as a treatment option, we sometimes do have radiotherapy as a treatment. And in testicular tumor, definitely in seminomatous tumor, for early stage disease, radiotherapy still remains one of the treatment options. So chemotherapy is also coming up in the early stage of seminomatous disease. So thank you, Dr. Parul. If the residents do not have any query, I can't see anything in the chat box. Thank you very much for joining the session today. And I would request you, it would be a great idea if our residents can visit to your department sometime, and you can show them exactly how the radiotherapy is being given, brachytherapy, teletherapy, and all other different modalities of radiotherapy.
Yes, sir. Yes,
so I would request one of my residents to contact you, and they can plan a visit for it.
Yes, sir.
Right?
Sure, sir. Anytime, sir.
Thank you very much. Thank you, Parul. And thank you all the residents and faculty members and all the viewers who have joined us today on Zoom and YouTube. Thank you very much.
Thank you, sir. Thank you so much.